The following video demonstrates a surgical technique using hip arthroscopy for an irrigation and debridement of a septic hip. Here are our disclosures. The patient in our case was a 19-year-old female with poorly controlled type 1 diabetes who presented to the emergency room with 3 days of hip pain and inability to ambulate. The patient's physical exam, laboratory workup, and CT scan demonstrated an infusion which were concerning for a hip septic process. Given the patient's presentation, we proceeded with bedside ultrasound-guided aspiration of the hip joint, which demonstrated grossly purulent fluid and cell count was 94,000, confirming septic arthritis, and we proceeded to the OR for an arthroscopic IND. After initial access to the hip is obtained from the anterior lateral portal, grossly purulent fluid was observed, and a limited lavage was needed to establish the mid-anterior portal under direct visualization. Both portals were achieved with periportal capsulotomies, without completion of a full interportal capsulotomy to preserve capsular integrity. After access to the hip is obtained, a diagnostic arthroscopy of the central compartment is performed to evaluate the labrum, femoral head, and the acetabular fossa for loose bodies in the peripheral compartment. After diagnostic arthroscopy is performed, an irrigation debridement of purulence and a synovectomy is performed using a mix of shaver and radiofrequency ablator device. Once a thorough debridement of all infected tissue is completed and a minimum of 6 liters of irrigation of fluid is ran through the joint, traction is let down on the hip and the femoral head is reduced and the suction seal effect of the labrum is observed to be maintained. We also demonstrate another illustrative case of an arthroscopic IND of a septic hip when at time of diagnostic arthroscopy a labral tear is found. Given the infectious nature of a septic hip, using anchors and suture materials is avoided to prevent anitis for reinfection. After debridement and synovectomy, a radiofrequency ablator is used to heat stabilize the torn labrum without destabilizing the labral integrity. After surgery, the patient can be discharged the same day if appropriate antibiotic care has been established by the infectious disease team. The patients are weight bearing as tolerated with crutches for 2 to 4 weeks without a postoperative brace, and they will begin early supervised physical therapy. The emphasis of physical therapy is on hip range of motion with progression of ambulation and hip strengthening with eventual return to full activities.